Um, Fundamental right, a discourse from gender lens with a special reference to COVID-19. Uh, I also welcome to all those participants in the audience who and are students of the university who have joined online, and also those participants who have been joining since morning from different parts of the country. On behalf of the Center for the Study of Women Studies, Maulana Azad National Urdu University, I welcome everyone in this program for a panel discussion in the afternoon session. We have with us very eminent guests who will be delivering and deliberating on the issues they work into. The panel discussions chairperson, Professor Sangmitra S. Acharya. She is a professor at the Center of Social Medicine and Community Health, School of Social Sciences, Jawaharlal Nehru University, New Delhi. Professor Acharya has also worked at International Institute of Population Sciences for quite long time. She also served as director of Indian Institute of Dalit Studies during 2015 and 18, which is one of the think tank in the area of Dalit studies. She was a visiting fellow at CAS China, Ball State University, USA, UPPI Manila, East West Center at Honolulu, and SICI grant in 2019-20. She has traveled to across the countries on the assignment and work which is concerned to the health and reproductive health and areas of public health concern. She has been one of the eminent researcher who has been working in the area of marginalizations, health, issues of land, labor and health, issues of marginalization in Dalit, caste, COVID, and care. Her work in the area of discriminations and exclusion is most cited in many of the research when one wants to study and understand the healthcare system in the country. Professor Acharya also served the chairperson of the center at JNU. We are very privileged to have Professor Acharya here as a speaker and also chairing this session. Thank you, ma'am, for accepting our invitations at Maulana Azad National Urdu University. Obviously, someone like me who will be more privileged because she was my teacher at the center in JNU. So we are very privileged to have you here. Many of the participants have joined from JNU. I can see they were asking for the speaker. So thank you so much for accepting our invitations. We have another panelist here, Dr. Swati Rane. Swati Rane is a Swati Rane is there. Welcome on behalf of the CWS in the webinar of on reproductive right and choices. I would quickly like to introduce Dr. Rane. She is an experienced healthcare entrepreneur, nurse, and patient safety advocate, activist, independent researcher, teacher, values and character oriented professional, and a mother with a PhD and MHA as her professional degree in nursing as well. She has done a lot of work in the area of health studies, health system studies. I can see she also worked at Tata Institute of Social Sciences, one of the pioneer institutions of the country that works in social sciences and in the field. Professor Dr. Rane has worked and do a lot of advocacy in the area of healthy work environment. Trains the student who work in the area of health, and also work and having interest in the area of attitude and behavioral trainings, strong research professional skill, practicing pranic healer, stress management, and holistic life management as trainer. She is professionally skilled in operation management, having analytical skills, medical devices, quality management, and healthcare. Her biodata and activities are quite long, but by reading her brief bios, I could only understand that she is basically very much concerned to the area of healthcare, which my interest also is, and the other areas which you could see that she has vividness in her experience. Welcome you, Dr. Rane, in this panel discussion. uh, I would also like to in continuation of introductions, I would like to introduce Dr. Veena Vaswani. Dr. Veena Vaswani, Veena Ravi Vaswani, welcome here, ma'am. She is Veena Ravi Vaswani. She is MD in forensic medicine and toxicology. She did her MPhil in hospital and health system management from BIT Pilani. She did masters from Erasmus Mundus, masters in bioethics in 2008. She is also PhD from Dublin City University, Ireland, and with that, she is a graduate in MBBS from Government Medical College, Nagpur. Her degree and area of expertise is very diverse, and to someone like we who are common and social science researcher finds that they are the one of the most valued professionals in the country who have intervention in biomedicine and working into the field. Her expertise in the area of healthcare is also because she is director for Center for Ethics, something which is very much needed in the area of public health, healthcare, and reproductive choices. She has lot many accomplishments. Started 2 ethics specific academic programs in postgraduate diploma in bioethics and medical ethics, first time in the country. She also started postgraduate diploma in clinical ethics, that in short PGDCAC since 2012. Again, this is the first initiative in the country. She did intensive summer workshop in ethics and research, choice-based credit course for bioethics and environmental ethics. Uh, the area of work on ethical area of work is something which is grossly less attended in the academia, either in social sciences or biomedicines. With this, we find that her presence in this panel discussion makes this panel more important, very significant. And to have you all here, we need to also have somebody who organized and who is behind and with this program, Professor Shahida, Director, Center for Women Studies, and Head of Department of Women Education at Maulana Azad National Urdu University. I welcome you all here in this panel discussion. We both are live from the studio, and all the other guests are live from your at locations due to COVID-19 continuations. Welcome you all again, and thank you so much for accepting our invitations. I would now hand over the sessions to Professor Sangmitra Acharya, with a small addition that the registrar of Maulana Azad National Urdu University, who is also dean of School of Education and Training, he has lot of work and interest in this area as well. So, sir will be joining shortly in this here at the studio. I wanted to just share to the chairperson that he'll also be joining the session. Over to you, ma'am, for this continuation of this session.
Very good afternoon to all my colleagues as panelists, organizers, Professor Shahida Murtaza, Dr. K.M. Ziauddin, and my co-panelists, Dr. Swati Rane, Dr. Veena Vaswani. I feel extremely pleased to be on the same platform as you in order to share this very, very important and contextual discussion which MANUU has organized. And I'm really grateful to the university to have considered something such as reproductive choices, wherein we place choices vis-a-vis rights, fundamental rights in that sense, and then connecting it to the current day scenarios such as health emergencies that we are reeling under at the I thought it was very different from the conventional thought that was happening across the academia in terms of the prominence which COVID had taken on board. I think to blend that with reproductive choices, also in the light of what National Family Health Survey 5 has thrown to us in terms of pondering over, and we've had some very interesting discussions in the forenoon. So I feel that this is the platform and this is the session which is going to bring on board many such aspects which we thought need to be brought far more vociferously in the forefront. And for that, I really wish to congratulate the university at the first go, and then, of course, the departments which have taken on board to bring this to us. The Center for Women's Studies and, of course, the Media Center of the university. Without the two to coming together and giving this thought, the execution that we are in at the moment, this wouldn't have been possible. So with that, I really welcome the panelists. Dr. Swati Rane, it's really very, very heartening to find you here amidst us. And many of us are familiar with your work as CEO of Save Shakti. And we really want to hear more from you on this very important issue. And I'm sure your sharing of ideas is going to bring out the trajectory that we are kind of struggling to understand in terms of what exactly do we say when we mean reproductive choices or reproductive rights, vis-a-vis what the fundamental rights have enshrined for us as women first, and then perhaps all other things that come in. And importantly, I'm placing women first for the simple reason that sex ratio, for the first time, I'm sure NFHS has given us this data, which is saying that it's on the favorable side of the women. So I'm sure my colleagues on the podium, virtual podium, are going to highlight on these issues. I would invite Dr. Swati Rane to begin this conversation, and I'm sure it's going to be very interesting. Over to you, Dr. Rane.
Thank you, Professor Mitra, for your beautiful way you presented all of us, and you made the session, broken the ice very well, in fact. And I'm very happy that my teacher, Madam Veena, is there with us, and I'm so happy. I'm always happy when my teachers are there, I'm safe.
And it's a different kind of pleasure altogether.
Yes.
I agree to that, yeah.
Yes. You feel like, you're in a basket again. And I'm thankful to also MANUU for taking up this important topic in COVID, where we have seen in newspapers regularly this is happening. And when Madam Dr. Shahida discussed with me, she was so much interested with her soul in it. And that is very important, that women stand for women today. And I thank also Professor K.M. Ziauddin for introducing me so lovely. And I was really impressed. We always don't know how much we work, but somebody tells, that time we realize that we are doing something good. And I'm thankful to all of you all here. So I will start my presentation. I'll just share my PPT. I have to just click on the share the thing, or how do I do?
Click on the share.
Yes, share screen. Yes.
Keep your PowerPoint open and click on the share.
Yeah, that's
Yeah,
easy.
I have done that, but I can't see my PowerPoint is already opened on my screen, but I can't see it here actually. Should I email in that moment? Or,
That's also an idea, yeah.
Sometimes it takes a while before it opens up for the rest of us.
Fine. So till the time I will just, till it opens up, I will just start with my presentation. So my topic is challenges faced by women healthcare workers during COVID. And with that also, I will be taking in the issues related to women and adolescent in healthcare. And the most important thing here is that it is
You
very
can
well. Yeah.
you can click on share and then
Yes.
then entire screen.
1 second, sir. I'll just do it again.
You keep open your PPT.
Yeah, PPT is open, sir, and I have clicked on my entire screen.
Yes. And
Share.
then share.
Yeah.
Yeah.
Yes, it's working.
Y'all can see the PPT, is it?
Now you go
Yeah.
to your
Go to
PPT page.
go to PPT.
Yes, now?
Yeah, now we
Yes,
Yeah.
can see it. Yeah.
you
Then
can
click
see.
on hide
Okay,
button.
fine.
And you
Click
can hide the,
na click the hide button
yeah,
is
yeah,
there na
in the
below
down
down.
But
bottom.
this, which is the one I have to hide?
No
Yeah.
no no.
You
There
can
is
go to
There is
slideshow.
stop sharing.
no no there hide.
No, one
Below
person, please tell me. Uh,
You
Yeah,
can
yeah,
go to,
click on hide.
yes, yeah, that's where you need to click.
yeah. Hide,
Yes.
hide. Thank you. Yes,
is
done.
it okay?
It's full now. It's full now. Yeah.
Okay, thank you so much. Fine. So thank you so much again for all giving me this opportunity. So the topic is challenges faced by women healthcare workers during COVID, and we will also be considering the women and adolescents here. I have to thank each and every person, the dignitaries and the college committee members of MANUU for giving me this opportunity, and I have to thank also to the all the speakers and the audiences for giving me their time. So here we start with Anisha Agarwal's quote, where she very well stated that women have been worst sufferers of COVID-19 due to multiple reasons. The pandemic warrants a reminder that reproductive rights are human rights, and they are surely essential and urgent. And that is the reason we have come here together. The United Nations agency says that 26.7% of the total maternal deaths are recorded in the world are recorded alone in India. Every 5 minutes, at least one woman dies of the complications related to the pregnancy or childbirth in India. That is according to WHO. So this is a situation which has come up to the surface. It was already on the surface, but now we it has come to a level where COVID has brought it to a level where we cannot ignore it anymore. So if you really see in COVID what happened, these are few newspaper articles which I have highlighted here for us to understand what the pregnant women or the uh, ladies in the reproductive age has suffered. So here you can see that pregnant women struggle to access healthcare facilities in midst of lockdown. So here at least estimated 1,400 to 2,000 maternal deaths might have occurred due to lockdown because of poor access to family planning during this period. In every 5 days, at least one case of unattended pregnancy comes to me. So this is said by a gynecologist from Delhi, which is very heart wrenching that a pregnant woman who is actually a healthy woman, she has to lose her life because the access to healthcare facilities is not there because of poor management or poor policy making. So prevalent lockdown rules, closure of private facilities, lack of mobility and disruptions in the supply chain have led to limited access of healthcare. Also, if you see, 75% of the mortality rate is COVID-19 pregnant ICUs. So, one in five maternal deaths are due to COVID. So, if you really see that it is uh, it is like a tight slap on our face, especially to the country's health department and also to the policymakers and who are sitting on the chairs, that if we cannot manage healthy pregnant women, okay, and if they have to lose their life, we have to think about it. So the most important thing is that we have to reduce the maternal mortality by 2030 as per the SDG goals. And every gynecologist, every nurse working, or every healthcare worker is very much concerned of this because they are very much ready to work. But if there are no proper policies, if there is no infrastructure, if the vaccines are not available, if there is no access for vaccination or no access for delivery of the babies, it is very much difficult to manage these patients. And actually, I don't think pregnant women are patients. Actually, they are healthy people Okay, so it is they are pregnant, and when they come to the hospital, it is a joyful mood for them. Okay, so I think we should not even call them patients. They are actually our clients, and they have to be treated well. They should not lose their lives. So, according to the CEO of FRHS, V.S. Chandrasekhar, he said that 20 to 24 lakh of unattended pregnancies might be happened during March to June period due to inaccessibility of contraceptives or abortion process. These unattended or unintended pregnancies might result to 5 lakh to 7 lakh of additional births in 2020, as many women who end up in the unintended pregnancies will be forced to carry these pregnancies to term because of inaccessibility of abortion care. So you can understand psychologically, financially, if the mother has lost her job or if the husband has lost the job, they must be going through so much of trauma. We can also see that both private and public facilities have shown that there is a sharp decline in accessing the OPD, or 70% decline is there in the OPD because of the nation's lockdown, which was there. So, all these ladies have really not got proper care. Another reason for the closure of the private health facilities was also that there was uh, absence of staff. The staff was not vaccinated, the staff were not getting PPE kits, so they were also at a risk. So every year in India, around 15.6 million of abortions takes place, out of which 93 to 95% are in private healthcare facilities. So this shows that, somewhere we have to strengthen our public healthcare facilities, because every woman is not from a privileged class, or every woman is not from a financial status where she can go to the private facilities for abortion. And abortion is something which a daily wage worker, or it is a service which is required through every class, every caste, and every strata of the society. So everybody cannot go to the private facilities. So poor and marginalized women are severely impacted. So again, here if you can see that Shehnaz, who is an ASHA worker who's based in Delhi, she stated that she was unable to attend pregnant women as she was reassigned to treat the corona patients in the government hospital. So in rural areas also, the marginalized woman or the poor woman has suffered. So in Mumbai itself, you can see only 1.6% of women were vaccinated. So you can imagine that almost 98% were not given the vaccine. It can be because of many reasons. It can be because of the misconceptions. It can be because of misinterpretations. It can be because of inaccessibility. It can be also because the women are not aware, or they don't have the rights to access healthcare, or they are completely dependent on their family members for accessing the healthcare, or even taking a decision whether she can take vaccination or not. So, access to safe abortion is a reproductive right and justice issue, and it is imperative that safe abortion access during and after the COVID pandemic is reality for all. It is estimated that 1.85 million women will be unable to access abortion services as near-term impact of COVID. And this is very challenging, and this is very heart-wrenching to see that is good, okay, but not getting the reproductive rights, not getting the facilities is the worst for any woman of any age. So there are a lot of challenges which we can see for the woman to access healthcare. So here I'll be taking both the healthcare workers challenge and the women's challenge. So here we could see that the limited mobility and access to healthcare was there because of lockdown. Abortion pills, usually if you see, because many of the uh, men had lost their jobs. If they were working in the cities, they had gone back to their villages. And definitely the abortion rate, the conceiving rate was high, but the abortion uh, activities or the services were not very much there. So about even the pills were not accessible because of the lockdown. So abortion pills were purchased by the male partners from the local pharmacist, already creating a barrier for a woman for getting the direct healthcare they need. So here also you can very well see in this paper that even purchasing power, if the woman is not having, if she is dependent on a woman, dependent on her husband, it is very difficult for a woman to get the right facilities, delay in access to avoid the scrutiny, because many of the police personnel were avoiding people to travel. So many of the abortions were, missed at the right time. So that was one of the big tragedy what was happening. Lack of clarity was there about the abortion. So whether it is an essential service. So after almost 20 days, the government of India declared that it is abortion services is an essential service, but it was not gone. It didn't really went down to the grounds. So many of them didn't have had even lost their lives, pregnant women, because they had to just move from one hospital to the other hospital. Lack of clarity of the abortion as a service, okay, through telemedicine. So initially a lot of telemedicine was happening, but abortion activities were not considered, and shutdown of the services also had a lot of issues for providing long acting and permanent method of contraceptions. So changes to decision making about the birthing and parenting during a pandemic are the factors that may impact the demand for abortion during and after lockdown. Shortage of raw materials was big problem. uh, Transport was a big problem. Medication supply was a big problem. So these challenges are further compounded by the caregiving responsibilities, limited public transport, and fear of contracting the virus, resulting in additional delays in seeking care. Research also shows that a minority of abortion providers in public and private sector provide abortion beyond first trimester. And even among these facilities, only few provide abortion services up to a legal limit, as per the paper written by Singh and others in 2018. This could make access to abortion extremely challenging again in the pandemic situation. Service providers may be adopting measures to mitigate the spread of virus. So here again in the hospitals also, they were not directly taking the patients, because that time in the first wave vaccination was not there. So they were very much careful of the division between which hospital is COVID hospital, which hospital is not COVID hospital. So again they also had to take according to the appointments, according to the client flow. So lot of issues were there, even to go to the doctor or to switch from from the operations point of view or the running of the hospital point of view. How to access healthcare was very difficult, and there were many delays. This I have covered. So let us understand that who are these healthcare providers. Okay, so all these activities which are happening in the hospitals or in the community healthcare centers, there if you really see globally, women account 70% of health and social care workforce. Okay, so the delivery is done by the women, the gender is women. Okay, so they were less likely to be, again here you can see there is with the gender lens that again there is a disparity in their pay packages also. And also if you see that the delivery is done by the women but the decision is taken by the men, that we can see in the next slides. So by 2030 around 40 million new jobs will be created, okay, because of the rising demand of the because of the rising demand of the healthcare demands and the demographic changes. And now pandemic has again put us into big problem. So from where are we going to get these women, because 70% are women. But if we are not going to use proper system for bringing in the women in healthcare workforce, it is going to be a big difficult. And again, if you see that many of the nurses who were working in during COVID, they had lot of reproductive problems, because they had to work almost 12 hours in a duty in that PPE kit. They couldn't go for their nature's call like toilet or something, or if they were having their periods, they had to manage that whole thing. So lot of issues, women related issues were there. So now if you can see that there is a shortfall of 18 million healthcare workers. okay, mainly in low income and middle income countries. So if we are not going to have the healthcare workers, who is going to take care of the system, or who is going to take care of the healthcare services? That is a big challenge which is there in the healthcare now. Now also we can see that the payment, okay, majorly there is a lot of discrimination, because 70 to 80% is private healthcare, and private healthcare is churned by the owners or some private person, so they don't pay them very well. Like in government jobs, they are very much settled, they are having lot of benefits. But in private sector, if you see that a nurse in private sector may not draw more than 12,000, and if you compare, a driver draws more than 20,000 in a city like Mumbai. So why will these nurses come ahead and take care of the patients? Okay, so global health is delivered by women and led by men, and this is not fair and smart at all. uh, Mapping the problem, global health and care is delivered by women and led by men. Here we can see there is lot of stereotypes going on between the gender. If you see with the gender lens, majorly the doctors who are there, they are in the higher hierarchies. If they are male doctors, there are a lot of hegemony. So even if there are female doctors, they have to bear a lot of their egos. Okay, so women's disadvantage intersects with and is multiplied by other identities such as race, age, hegemonies, hierarchies, and class. Global health is weakened by excluding female talent. If you see in COVID-19 task force, we hardly see women's voice. We hardly see women doctors. We hardly see women social scientists in the COVID-19 task forces. Even today, after 2 years, we hardly see any women leaders in any healthcare agendas, in any healthcare forums, given the right to talk about women's choices or women's needs. So if you really see, this is a women's representation in global and national level. Women are almost 70% working, but 25% senior roles. You can find only 25% women in the senior roles. And if you see, 90% are nurses who are working on ground. Okay, but they are managed by the hierarchies of doctors and the managers and the hospital administrators. So who is going to talk for nurses? Like in Mumbai, when the COVID started, the nurses were not given PPE kits, they were not given N95 masks because they were not available. So they were very clear that you will not get, because your nurse, we will give it to the doctors. And then when we brought this issue to the chief minister, on the same day the flight was sent to get the PPE kits, and they got the PPE kits, and then they went and took care of the patients. So at this level, the discrimination of women are there in the healthcare. So if you see that overall, okay, the major healthcare workers on the ground are ashatais. So more than 1 million ashatais are there, and you can see for past 2 years, if you see that they are almost going for strike again and again, because they are getting a negligible amount. Just they are getting around 4,000 to 5,000, and they are working for more than 8 to 9 hours per day. And now they have been given extra duties also. Other than their work, they have to go and do the COVID duties. Okay, in similar way, sanitation workers, okay, they are completely ignored. So many have died, but there is no maintenance or a list of how many sanitation workers have died. In that, there are many women also. So here, if you see in this chart, National Commission of Safai Karmacharis, a non-statutory body, it is limited in scope. So what they have said, that it is limited in scope problem. It being a commission cannot approach the Supreme Court to assist in setting a feedback response from state. Even compensation for death, it is difficult, as it's a political issue. So here, if you see that even the chairperson, okay, he doesn't have a voice, okay, to fight for his karmacharis. So where are we, what are we looking at? There is nothing called as a data available. How many have died, how many are COVID, how many are infected with COVID? And if these things are not there, if they are not working in healthy working conditions or healthy work environments, how are they going to give care? And if the health worker is not healthy, I'm sure the patient cannot be healthy also. They were not given any trainings, they were just told to just work. They didn't know that COVID can be spread so rampantly, and how much difficult it is to come to get the access for the right treatment. And many of the Safai Karmacharis have lost their life, and also they have carried this infection to their houses because of ignorance or no awareness given by the hospital administration. So here we have to define the categories of the healthcare workers. There are many women in healthcare workers, and they have to stand and they have to demand that these are the works, because today healthcare has changed completely. Healthcare is nothing like it is given only in hospitals or dispensaries. Healthcare has come to your house through telemedicine. Today, phone consultations are there. So now the requirement of the healthcare workers, or the definitions of the healthcare workers, or the job descriptions have changed, and we have to come together and redefine the whole structure. So if you also see in the gender distribution, you can see there is a completely skewed picture. Okay, the way the whole healthcare structure is, that there are more nurses, less doctors. In some areas there are you can see also that the gender discrimination is there. Again, more doctors are males. Okay, more dental specialists are males. So here also you can see the discrimination, which is very much there. So all the gender inequalities are systems inefficiency that contribute to the clogged health worker educational pipeline. Okay, recruitment bottlenecks, attrition, workers maldistribution in formal and non-formal healthcare workers, and it has implicated in a wide variety of health workforce consideration. So workforce structure and concentration hierarchies are there, which is again creating bottlenecks. Lot of gender sensitization is required today. The gender sensitization training is required to be given to the healthcare workers today, because these are very the patient is very vulnerable when the patient is coming to give for the delivery of the child. She's very vulnerable. She's in a very compromised position. So if the healthcare worker is not gender sensitive, okay, lot of gender discrimination can happen. The female composition of the workforce should be increased in the primary healthcare centers. The female nurses, community healthcare workers, home care givers, okay, their pay should be at par with the industry. And that's the most important thing, because if they are not given proper pay, we may not get the good care from them. So this is somewhere, we have to think about it. So I think almost we have covered this: differences in wages, healthcare workers' mobility, perception of health and quality of life among the healthcare workers is very, very important. Stereotypes I have covered. So here you can see lot of nurses are going on strikes. Okay, because now the government is taking contractual staff, and contractual staff is not getting healthy work environment. Health benefits are not there. Work benefits are not there, and you cannot expect a professional to work 12 hours per day and not get proper benefits or proper remuneration. So nurses regularly, you can see they are going on strikes. They are also not getting proper PPE kits. The nursing ratios are poor. They are not getting N95 mask in some areas, especially in government hospitals, which are in the interiors. There are insufficient gloves. So their own life is at stake. In Maharashtra also, we have almost fought a lot. We have done a lot of advocacy campaigns. We have written letters to Chief Minister for stopping all these things, because most of the deaths, okay, in the of the healthcare workers, especially the nurses, in the first wave there were 62 deaths in 8 months. In the second wave, 62 deaths in 3 months. So you can imagine what would be the cost. Has anybody done any analysis why the nurses have died so much? Have they checked whether they have got all the vaccinations? Because 70 to 80% is private healthcare. Has the private healthcare taken care of their own healthcare workers? That is a very much important thing, because we have seen nurses not getting healthcare COVID, after infection with the COVID, they were not getting beds, they were not getting treatments. Vaccination was a big issue initially. Getting PPE kits was a big issue initially. So all these things are there because there is no voice in the COVID task force. There is no nurse in the COVID task force, not at the national level, not at the state level. So I think this is somewhere, we have to stand up for. Shortage of nurses is a global issue. We all know about it. So overall, if you see that healthcare workers are having lot of issues, okay, they are not only threatened by their superiors or the hierarchies in the hospital, but also many nurses were not given place to stay. They were discriminated, stigmatized, and they had to come out of their houses because of the threat that the other people in the building may get COVID. So many of the nurses had lot of issues. The patients were not good with them initially, and lot of psychological issues they are going through. So in India, nursing as a profession gets caught in the hierarchy where doctors are considered superior to the nurses. This is our own Dr. Anand Ban, who's a great researcher and who is working in health policy and bioethics, had mentioned. Capitalism and cheap labor go hand in hand. Unfortunately, women are the cheapest labor, both in home and outside. Late Kamala Basin ji had said, and it is very much true. How much ever educated a woman is there, okay, she is not being treated well because of the patriarchy which is being followed here. So again, gender sensitization is very much important, and we have to stop, okay, all these things, and we have to, a woman has to stand for women, and such workshops or such deliberation or discourses should be brought in, and we have to talk with the government and the decision making bodies. So this is a very good picture by George Asha, where she shows that the violence against female health worker is just at the tip. So much is there which is not even spoken about. They are not allowed to speak. There are many of the nurses who are just 21, 22 years old, just freshers, and they have to undergo a lot of problems in their career, okay. And also the pay is a issue, getting safety kits is a issue, space is a issue. So all these things, who is going to talk? The gender inequality, gender biases, gender power relations, these are the issues which are not yet spoken in open. So tackling gender power relations is key to ensuring the safety and well-being of the healthcare workers and the ability to deliver quality care. That is what Asha George says. Most important thing is that we have to empower this whole healthcare system. We have to empower the women healthcare workers with male healthcare workers, definitely, and they have to stand for their own rights. That is what I feel. We have to have professional associations, organizations, regulatory bodies that govern the healthcare and the healthcare workforce, require leadership that is more representative of gender, occupation, other relevant social backgrounds. So here I would suggest that we have to from the society, we have to stand for the nurses and doctors for their safety. If we don't do that, then who is going to do that? And it should be a complete zero tolerance, okay, at the workplace. Violence should not be tolerated at all. So here also you can see many doctors, young doctors are working in unsafe environment. Many of them during COVID had lost their lives, or they were beaten up by the patients because of the patients' relatives, because they have lost their because lot of issues were there. Oxygen was not available, doctors were not available, the flow of the patients was high, but the citizens did not understand this, and lot of violence the doctors have faced. Especially the women doctors, if you see, they had faced lot of issues. So most of them were doing lot of telemedicine in India, okay. Here again, you have to understand that women doctors, they are working on in night shifts, they are working sometimes alone in the wards. So these are the people for whom we have to stand for, okay. So this slide shows that even these women doctors, they have to manage their houses, they have to manage their small children, and they have to manage patients. So today, if we want to stand for good healthcare system, the citizen should stand for the healthcare workers. The citizen should demand good quality healthcare and good quality of professionals, and the government should invest in it. Okay, so challenges to the Indian healthcare system for maternal and child safety, I would suggest that strong public health policy, legal frameworks, laws, regulation, policies, strategies on quality of care, they exist in the country, but they are still largely fragmented. So we have to demand these things involving women healthcare leaders and women, even the end users, the women patients, adolescent girls, boys, they have to come in developing the policies and the infrastructure. What type of hospitals they want, what is the infrastructure they want, how should they develop, what should be involved in the policies. So all these things, I think we have to teach to the adolescents. So today we have to invest. Okay, we have to a targeted investment in sexual and reproductive health of adolescents in India is vital to reducing unintended pregnancies, unsafe abortions, unplanned births, maternal deaths, as well as to ensuring bodily autonomy and well-being of the country's young population. Because today they know youngsters today are not going to schools and colleges. Okay, most of the time if you see, they are with mobile phones. Okay, so where how will they socialize? And definitely there is increase in unplanned pregnancies. So we have to have a rights based policy framework is needed to prevent reproductive coercion and ensure equity in access to the services. Strengthen the national laws and policies to protect the rights of adolescents to sexual and reproductive health care. Young people must be meaningfully engaged in conceptualizing, designing, implementing, monitoring, and evaluating the programs. And here, the role of colleges is very important. They have to guide them, they have to discuss all these issues with them, and create policies for them in accordance with the guidance of WHO's Global Accelerated Action for Health of Adolescents. We have to also understand that there is a following shifts in the policy programs practices will be required in order to meet health goals set at state and global levels. We have to help the adolescents, make them to form their decisions. Okay, so high quality, inclusive, accessible, non-judgmental contraceptive counseling is the need of the hour. Or healthcare workers must be trained in how to provide adolescent friendly services, including how to provide respectful, non judgmental care for the young people, regardless of their marital status or gender. Healthcare workers must provide adolescents with accurate and non biased information. Government planning, family planning programs such as Mission Parivar Vikas should broaden their language so that the message about preventing unintended pregnancies apply to all, regardless of their marital status. The high rates of child marriage found in some states must be addressed through increased education about harmful social norms and practices that perpetuate early marriages, and by enforcing legal age of marriage. This type of multi-pronged approach is necessary to ensure girls' physical safety and reproductive autonomy. To the women on the front line, we have to thank all of them, because out of 10 nurses, 9 are women. Out of 10 aged care, 9 are women. Out of the child caretakers, out of 10, 9.7 are women. Out of the kindergarten teachers, out of 10, 8 are women. So they deserve good recognition, fair pay, and respect. And I thank all of you all for giving me this opportunity.
Thank you so much, Dr. Rane, for bringing some very pertinent issues on the floor. I would request the audience who's live and who's connected to keep placing your questions or views in the chat box as we move ahead in this conversation. Dr. Swati had really brought together the nuance of what is happening to the healthcare providers and providers who are at the comparatively second tier of hierarchy, unlike the doctors whom we associate at the highest level of hierarchy. Nurses probably are placed subordinate in that hierarchical position. And what is it that they have undergone? Dr. Rane has really brought very clearly the perils of being a healthcare worker during a pandemic, and what are the issues which get accelerated when a health emergency occurs. So thank you very much, Dr. Swati, for bringing that on board. In the meantime, since we are fairly all right with time, just about 5 to 7 minutes delay, I would wish to call upon Dr. Veena Vaswani before we open the discussion, probably because I see the connect in all the speakers, all the deliberations that we are having, so we can get into the question answer perhaps after we've all spoken about our issues. Dr. Vaswani, thank you so much for coming on board, and we are really very keen to listen to you in terms of, I'm sure there'll be a lot of ethical concerns that you're going to raise for us to think about. So I really look forward to listening to you. Over to you, Dr. Vaswani.
Thank you. Just a minute. Can you see my screen? Yeah.
Yes, I think it's opening. Yeah, it's there. It's very much there.
Okay. Thank you. I'd like to place my gratitude for having me on this podium for discussion, because it's more than what we speak. What we get enriched is a reflection of ideas and a loud thinking that does end up with a coalescing into certain actions. So I would like to thank the MANUU for having me here, and the Center for Women's Studies. And I would like to bring in my perspectives on the point for consideration is, when I talk about the impact of COVID-19 in general, I would also like to bring into how does it specifically affect women, and then it narrows down to how does the reproductive health get affected, and later on about what would be the impact and how are we to go from here. So when the COVID-19 crisis impacted, the world's poorest and the most vulnerable were the hardest hit. So with the significant intergenerational implications for poor families. So when we say intergenerational, because there are certain times, certain actions, certain transitions, like pregnancy is one, childbirth is another, and then sexual assaults, molestations are some, which have an impact on the person. So we are just bringing that into the fore, and also 4 billion people accounting for nearly 55% of world's population. That means 2 out of every 3 children have no adequate social protection to start with. So imagine when COVID hits, how then are they supposed to go? What umbrella do they have to get some succor in such a time? Because the ILO has put these figures that the lack of social protection leaves people vulnerable to ill health, poverty, inequality, and social exclusion throughout their life cycle. Meaning, if you're already vulnerable, and imagine a time like this where your ill health and poverty become so intricately related that you're going backwards in progression, you're literally regressing than progressing. When you're removed from your social protection, nearly 4 billion people worldwide, it's almost denying them of the human right. We are not talking just of fancy rights, but the basic human right of social protection is removed. Now, COVID-19 has resulted in impacting women more generally and as frontline workers specifically. It has further widened the gender gaps through long-term health and economic impacts. It will affect the health in the days to come, because even though with whatever type of measures we are having, this is still not a good representative of what we're going to face in the years to come. Because like Swati Rane put it beautifully, like tip of the iceberg, we can see a part of it, but underneath lies a huge burden which we are even unable to fathom. Besides immunity and medical reasons, which help women tide over COVID-19 mortality-related crisis, the economic crisis, like loss of jobs, which was more for women than men, has literally got them to the wall. It has pushed them to the wall. Most unorganized sector jobs at the lower rung are also taken up by socially weaker and disadvantaged, be it by caste, creed, whatever, and they are also impacted. More women who lost out on jobs because they did not have a telecommuting facility, they did not have a good IT digital knowledge, like they were like a bartenders, travel front desks. So these jobs were loss of jobs for real. They could not then move on to the digital world. Women earn less compared to men. For example, in India, women earn 75% of what men earn. In US, 85%. In Australia, 86% of what men earn. In spite of this, the quantum of job is not less. The burden of job, in fact, is much more because they need to take care not only of the job what they are at, but also home, which is their first duty. So hardest hit is also a single parent who has lost a job or who has lost a caretaker during COVID times and has to continue with job minus them with the family responsibility. So imagine the plight of the frontline COVID workers. They literally led the nation, and they were the ones who were put to lot and lot of burden beyond compare. Lack of domestic help, childcare help, caring of a bedridden aged family member, pushed into household chore because of lack of internet connectivity, homes becoming a den of violence, more and more demands for food, and more demands for sex. So this is how the gender gap looks like. That during this time, we are already on the COVID-19 in the gender gap report of 2021 puts it that health emergency and economic downturn have impacted women more severely than men, reopening the gaps already closed. We have taken a step forward before, but we have taken number of steps backwards. And how are we then going to make the adjustments required to be progressive? And if this is the race that is run, aren't we sure about what's going to be the outcome of the race, looking at the obstacles before a lady? So we need to keep in mind the intersectionality, the multiple factors that influence a person, and the multidimensional understanding of identity. Many years back, I attended an interview where I was asked to introduce myself in 1 minute. And I was saying that's not enough because that might only give my name as a passport identity, but not my actual relational identity. So this person said, "What is your relational identity?" I said, "Yeah, I'm the mother of 2 kids below 10, and I'm also a doting wife and a daughter-in-law for a mother-in-law, father-in-law, and an extended family, and a very doting daughter." So imagine the relationality of everyone and look at that in relation to the female, and imagine the COVID-19 hitting in, and especially if they are females of color and the race, or let us say caste in India, because we are so caste conscious, and especially the divisions have increased so much. Lack of wealth, religion, region, custom. So these cause more and more oppression. As a forensic person, I can tell you my walk has not been easy. On the very first day in MD, I was told, instead of making rotis, why did you come for MD? You think forensic is like making rotis? So that wasn't many years back, yet it was, like I would say, it was in 93 to 96. But the thought processes have been very much in the genes of many of the males today. So when we are addressing about this, we need to somewhere tease out what has caused this. Because unless we address at the very root of discrimination itself, no amount of just having a power is going to help. Power dynamics, a role in multiplicity and complexity, we need to keep that in mind. the race, gender, economy, job, and interacting factors. And we also need hard questions to ask ourselves. Are we in some way denigrating our own people? Are we in some way making a kind of sly remarks on other women? Is it required to be made? For that matter, are we standing in solidarity with people? We need to do. So these are intersectioning realities and also uphill task. Why? Because all things remaining constant, competition has become more uphill for women. Workload has increased, jobs have decreased. An estimated 57 million unpaid voluntary workers, because Swati also quoted this, and I'm very I'm quite shocked to know how are we going to make up this bulk of long-term care coverage that we need. Where are the people going to come from? So you're going to take women into it, fine, but will they be paid well? Will there be other things in place so that they can look after their families as well? Because they did not happen in case of COVID times. What we looked at essential service did not percolate down to reproductive right. It did not percolate down to the maintaining of the home. And so with pandemic taking over, what happened with the reproductive rights of the women? World Health Organization advised on not closing down sexual reproductive services. But that was not taken seriously because for many people, the lawmakers are men, and these decisions pertaining to females are better not made because they are really not so important. So according to them, the sexual and reproductive services were not considered essential. The abortion services, contraception services were just not available. The impact of this resulting in unwanted pregnancy, continuous abuse, and lack of access to healthcare. Counseling had lot of teenage girls and girls within a family not being able to speak up, and ripples of gender-based violence have become spread across. From forensic angle, I have my own doubts. What happened to those who were violated, who were sexually assaulted, who were abused? Did they even get a mention? Did they go to the police station to file a complaint? Were they even welcome? Or if they complained against their own family member, then how would they go back to the family? So did that, in fact, breed a systematic violence, both sexual and physical? Because this is something that we really need to put across and find out what happened to our girls then. So reproductive choice of a woman is a fundamental right under Article 21 of the Constitution. In general terms, reproductive rights are the rights of individuals decide whether to reproduce and to have a good reproductive health. It includes an individual's right to plan a family, to terminate a pregnancy, use contraceptives, learn about sex education in public, in schools, and to gain access to reproductive health services. But removing abortion from the essential services, and this resulted in breach of this right, and it caused disproportionate harm to women due to the possibility of becoming pregnant. And this was not a possibility, but in reality, the numbers were quite high. So right to equality in having a choice in reproductive decision, and right to reproductive security, and right to reproductive services. Was it there? It was removed for a month or two. Is that a big thing? Yes, it is a big thing. Why is it a very big thing? Because when you started, it is like the WhatsApp university messages go across with a huge rigor than an office ordinance or a letter, because everybody likes it. So the moment you said no reproductive services, these are not essential, that makes rounds. And when you say it becomes essential, till the grassroots level, it does not percolate. It is not taken with the same sense of seriousness. On the second thought, they have allowed it. Or maybe it's only to pacify somebody. So that is why the rights say you can choose whether and when to marry and start a family. But yet, in COVID-19, many minor girls became pregnant with safety net of school gone, because schools are very essential part. When children are growing up, they're not confiding in their parents, but more to the teacher. And many a times, the child marriages have been stopped thanks to the intervention of the school teachers who have gone back to parents. So who have taken the necessary action. So, but here, with the school safety net gone, they were forced into marriages they did not want. A promise the fundamental rights of, they also promises the physical and mental integrity as a part of reproductive services, reproductive right. But this was taken away right in the confines of the homes and dwellings, and there was a physical, there was a mental, there was an abuse at every level. And we are aware of the numbers of abuse going up, but there wasn't a quick fix or at least a measure in place who they could contact immediately. At least these messages did not go across uniformly to people. And the right to equality in reproductive decision would have the HIV, STI, sexually transmitted diseases to be treated. In reality, lack of healthcare access to contraception services, and in fact, there was a shortage of contraceptives. And then people thought, oh, it's okay, they're not required at all. But they increased the HIV and the STI. And how many of them even came for examination when it was really nice, required to be given, so could be nicely treated? It did not happen because they had to wait. And many a times we know what happens with the long-term sequelae of a chronic sexually transmitted infection. The result of the lockdown has been devastating on women and girl child. Socio-economic consequences of abuse, unattended, untreated, and unheard, they have resulted in literally regressing and not progressing. In fact, they could echo as a post-traumatic stress in the years to come. 7 million unintended pregnancies and thousands of deaths from unsafe abortions. And in fact, plain simple, deliveries resulted in complications and death at home. Skyrocketing of gender-based violence, which was described by Natalia Kahneman, who is the executive director of UNFPA, as a pandemic within a pandemic. So we were having a pandemic, everyone was aware of it globally, but in many of the low socioeconomic countries, there was also another pandemic which was brewing, and people were not hearing much about it, or they were quite not so sensitive to the fact. So this is the Mary Stopes International, one of the largest charities. They estimate closure of contraceptive services and healthcare impact that 9.5 million women and girls have lost access to contraception, 2.7 million unsafe abortion, and 11,000 pregnancy-related deaths. So closing down of abortion services, and especially this, they also operate in India and Nepal, but millions could not access. When you opened it later, now come to think of it, when they said it's possible you could access them, there was no public transport available. In fact, many a times our own health workers got beaten up by police because they did not like the ID that was being shown. It was not in a particular format. So you can imagine that the barriers become much more than the access. So even then, with now abortion services being available, the disruption has already caused 26 million couples who could not access contraception, and 2.3 million of unintended pregnancies and 800,000 unsafe abortions all over the world. So Government of India is now classified abortions as essential after 3 weeks of lockdown, but the policy did not trickle to the ground level. All healthcare was repurposed only for COVID-19. Shortage of public transport, PPE kits, supply chain, pharmacy closure, shortage of contraceptives. And actually, this was not only India, the global shortage of contraceptives, they have increased the risk of STD and HIV, but who did not even have access to getting tested, so more sequelae and complications. So, what needs to be done? The human rights and gender impacts need to be studied so that the policies are well informed and benefit of vulnerable and the deprived are kept in mind. Now, after coming out with such a, let us say we have a data, are people really listening? Are we converting them into working policies? Data from participation of groups that are neglected can be disaggregated on the grounds of discrimination, human rights law, age, gender, socioeconomic status, migrant and health status. So they give us an idea as to where this could have worked and how best can we fortify so that we are well prepared for a disaster or a pandemic. Focus on most vulnerable through ensuring continuity of services in fragile settings and supporting efforts to fill gaps in tracking and reaching vulnerable populations in all countries. This is the time where solidarity should have been at the forefront. This is the time where divisive forces should have seen that there is more benefit to everyone if we stand undivided or if we put up a brave front of helping each other. The voices are heard only when the group is represented in decision making. This is very important aspect because imagine metros are being led down and then even the access sometimes is not disabled friendly. Why? Because they are not even a part of the process of planning or execution or studying the impact. So we need to consider if we are making something workable to a group of community, that community needs to be represented. And also wherever possible to support the survivors of gender-based violence, vulnerable and children who are out of the safety net. What can we actively do? What can we do with cooperation of others or with the collaborations? Mitigate impact of crisis on women and girls, including on their access to sexual and reproductive health rights. Now, this is a strong right. It should not even have had a second thought to make it essential or no. So, protect women's rights and girls from domestic and other forms of gender based violence, and also from financial resources, decision making process, and access to effective remedy. One of the most important things that came out, according to me, was the country lauded, they were appreciative of the ASHA workers. Countries appreciated the work of nurses. But going back to it, what has changed? Have we given a support to the ASHA workers who were so lowly paid? They took the brunt, they did the maximum work, they, in fact, to the extent of neglecting their own families. What happened? Just mere praise will do? Or do we need to put them into a structure of healthcare where, like Swati has already said, we need to give an hierarchy, a position where we recognize the work done? In fact, we don't even know how many of them lost their lives. So this is somewhere we need to look. A person as a person, be it a male, female, transgender, everybody counts equally. But then the glory today, if we handled well the COVID-19, the ASHA worker should not be left behind. So this is to conclude, in order to avoid pitfalls of ignoring sex and gender determinants, we need to have a general sex and gender sensitive approach, and it should be structurally implemented. COVID-19 sex-specific mortality brings to light the importance of incorporating sex-specific variables in the beginnings of the study. Whichever study we are even going to forecast or use it, we should have this to have communities of the vulnerable groups represented in the policy. And we hope that the Generation Equality Forum, GEF, would become a reality, and there would be a time when we don't have to fight for our rights, but it's a right that should be given to us. Thank you. I'd like my special thanks to Maulana Azad National Urdu University, Center for Women's Studies, National Commission for Women, New Delhi, Chairperson of NCW New Delhi, Dr. Sangamitra, and also Professor Shahida Murtaza and Professor Vibhuti Patel, who has always been telling me to be vocal about what we have gone through. So thank you so much.
Thank you so much. Putting across the very, I would say, the most pertinent aspect of what we've all experienced during pandemic. And it's only few of us who've kind of analyzed and talked about it. And you very rightly said, Professor Vibhuti Patel is one such voices whom we've been listening to. You very rightly pointed out something which I think comes out in a very nuanced gender way, not only for women who have been associated as care providers in various roles of being a care provider, but also as women who could have been experiencing the brunt of the pandemic by way of losing the wages, by way of losing a loved one, by way of the stay home protocol, bringing in the realms of violence against her, taking care of the children at home, sitting with them while the kids were doing classes online, and so on. So I think this was something which you've really brought up together in a nutshell, in a very neat form. I know one can go for hours together on an issue such as this, and as some relevant data is also coming up, I'm sure there'll be more deliberations on this. And once again, request the audience to probably put their questions in the chat box, although I'm not seeing any questions over here. But if the organizers allow, I would want to open the discussion, the two papers, because I think my role as chair probably should be differentiated with my role as a presenter. So I thought I'll probably open the discussion for these two papers and then assume the role of a presenter. The participants offline and online may please put in their observations, their queries at all, if at all they have any. I'm sure there'll be plenty, because these are some of the things many a times we just overlook. We don't even think about what's happening around us. We've been talking about gender sensitivity, we've been talking about gender sensitive approach, but when it actually comes to executing it, it becomes really difficult. And while I think Dr. Rane was mentioning about the task force, which Dr. Vaswani also talked about, I quickly tried to glance through the composition of the task force. And you're absolutely right, out of the 5 key persons, it's just one women member who's there, the health secretary, Dr. Preeti Sudan, I think. She's the only member at the helm. There's a possibility that there'll be other women members in the larger subordinate levels. But then the decision-making process really doesn't take note of people who are there, who are being affected in various forms. So I think both the presentations bring this out very well in terms of the intersectionality, which becomes very, very relevant when we want to talk about gender lens. Gender lens necessarily has to go beyond the differentials between men and women. What are the processes which are creating these differentials become very, very relevant. And I think that's where, when Dr. Vaswani pointed out that nurses, and I think Dr. Rane also said, nurses had to leave, they were kind of almost mistreated on, if I recall the report from All India Institute nurses, in their regular shopping center, they were kind of mauled away on the pretext that they will be spreading the virus. Similarly, the pilots of Air India, if I recall correctly, Cochin, I think, where they had to leave their residential premises and so on. So you're absolutely right. Our role as a citizen, how does that function vis-a-vis the caretaker, vis-a-vis the elderly, vis-a-vis, I mean, all other entities that we probably would want to put across in our roles, what you said as passport identity versus relational identity. So I think that was a wonderful concept to talk about when we are using gender lens to discuss the nuances of particularly something which is as important as pandemic. And I'm sure this is going to stay with us, given the history of other pandemics. I'm sure it wouldn't vanish. It will probably mellow down to levels where we can coexist, but it's going to stay with us. So might as well. And as the feelers perhaps are, some of these sessions online are going to stay with us in future. Some of the institutions already working on the 2020 or 50-50 kind of models vis-a-vis workforce. I'm sure these are things which are going to throw up new challenges which we need to put on board. I still don't see any questions in the chat, so probably I would request, there's something. Shiv Kumar is placing Ashas are untouchable groups in health. Okay, that's a comment he's making, that Ashas almost are treated as some, and I think that's also because they are at the most subordinate, lowest level of the hierarchy, vulnerable in terms of their educational levels, vulnerable in terms of even being young women. I would say all this contributes to their vulnerability, especially if we project them against the A&M, who could be older in age, who could have more experience, etc., training perhaps, and so on. So I'm sure Shiv, if either of the two panelists would want to elaborate on that, please go ahead. Yes, Dr. Vaswani.
I would think that they are the national resources, and we need to build on them in a way that they are also benefited, but the system also benefits. Because if they are brilliant and they would like to go higher up, then we should be the ones to open the doors for the education that they would like to pursue in future. Because it's very difficult to find people with passion in their work. But if we find somebody, then we need to go all out to accommodate them with the job that they love to work in and create these environs. Because instead of kind of looking at them and saying, okay, they are at the lowest, but I would think they're the resources, they handled the country, they were like the atlas on which we were resting to a great extent.
Absolutely, absolutely,
They were the ones who
absolutely,
were literally kind of thrown stones at and they're made to evict, but they stood their
absolutely.
ground. So we
Yeah.
need to see what best can we do to them. How do we
Yes,
identify those who are interested? How do we build on their aspirations so that
absolutely.
their aspirations are met, but the country needs are also met? So
Yes,
I think somewhere
absolutely,
whereby we can link up them and put them in a place where we can encourage them, because human flourishing is one of the duties of a welfare state. We should allow them to go for
absolutely.
flourishing in a way that they would like to. So I think we should not miss out on this opportunity. Thank you. Over.
That's a very important point you said, Dr. Vaswani, because we've been having the shortage of health personnel. Perhaps this is one way to think about upgradation, if I can use that term a little loosely. And also, perhaps what I once recall Dr. Devi Shetty talking about, all the doctors in waiting, all the healthcare personnel in waiting. Can we bring them on board in terms of, some kind of, agreement by way of which they would be rendering their services in the parts where populations are stuck by COVID, or provide services for COVID health centers, etc. Instead of leaving them as unemployed young personnel who've already invested their best of energies and lifetimes in procuring those skills. So I'm really
I would
glad
like
that
to
you
add
wrote.
here, Madam.
Please, Swati, go ahead. Go ahead, Swati.
See, we have been having advocacy by in Maharashtra for ASHA workers, and we had lot of discussions with the health minister, and they also agree that they are working a lot. And if you see these ASHA workers, they are coming from very downtrodden class of
Yeah,
the society, and
absolutely.
also they are just a few of them have just 10th pass, but you can see some are even BComs and BAs. Okay,
Yes.
but because they are somewhere having a surety that they will get a job in government, they are having this passion. So these are the workers who are really wanting to go ahead in life. Okay,
Yes.
so we need to give them a place in healthcare hierarchies. We have to register them
Yeah.
because they are doing
Absolutely.
something very important. So if you see overall healthcare workers, except nurses and doctors, nobody is registered as far as pharmacists or who are in that category. But what about the technicians? What about
Yes.
the new healthcare caregivers? Okay,
Hmm.
how can I, as a nurse or as a public health specialist, think about giving my parents to a caregiver who is just 10th pass and trained by somebody? Because
Absolutely.
she's taking care of a life, but
Hmm.
nobody is thinking about healthcare workers at that angle, what important work they are doing. They're
Yes.
taking care of life, and what is the value of life today?
True. True.
Nothing. So I
Absolutely,
think these are
Dr.
the
Rane.
important issues which we administrators or public health specialists or educators have to ask to the government today that what are you doing? Healthcare workers who are being trained like ASHA workers, when I give motivation lectures to ASHA workers, they tell me like, I don't know the difference between a nurse and me.
Absolutely, absolutely.
The nurse is, I don't know the difference between doctor and me. Because in the PHC, a nurse is doing all the work what doctor is doing.
Yes, absolutely. So
So, this is creating lot of what do you say? These are the real peoples who are the real heroes or the heroines of the nation, but they are not even treated as villains today.
yeah.
So we have
I
to.
think this is the most opportune time that we should stop thinking that they are volunteer service providers. We need to recognize the services, the kind of awesome service that they have provided during the time when we were all safe, locked inside our respective houses. Most of us who were in the public sector, we were getting our salaries very much intact every month. We did not have to worry about the next meal. But here are these people who've toiled for their life, put their lives in danger without PPEs, we've already spoken about. These are the heroes whom we need to go beyond showering the petals, perhaps, and singing singing the songs to claim. I mean, not that that is less meaningful, but what next is more important. How do I acknowledge, how does my service get acknowledged beyond the song and the flower petals? So I think that's something which has come out very, very well. And I'm sure the organizers, I think we're doing fairly well in terms of time. So I'm going to go over to Professor Murtaza and Dr. Zia to probably take the command of chairing from me so that I can come in my role of presenter.
Yeah, thank you. In fact, we will continue this session as it was a panel discussion. I would not ask question, but I was also hunching upon two important things that maybe at the end, if you wish, you can respond that. When we see healthcare workers at the formal institution, we consider them as valuable. But the same lot when they are back at home in the social institutions, they are not considered. So this binary is very difficult to understand, and people don't locate this. The same populations at two different institutions are seen very differently. Second, that is it also because of the whole dominance of biomedical model, and then those who are trained in Western medicines are more important in terms of giving them power. So when you talk of ASHA workers vis-a-vis the physicians are always seen in that in the hierarchy as most powerful. And in Indian context, we see the large number of physicians are also from upper class and caste.
Yes.
Vis-a-vis what Shiva Kumar was raising here, ASHA workers are untouchable. So these social indicators becomes more critical to understand, and probably in common everyday life we do not see and understand, because it's more of into the discussion of intellectuals and academia and researchers, not in the society. So that I think needs more discussion, and you may respond upon. But thank you so much for opening up and having very wonderful discussion. We do not want to break this rhythm, and I request you to talk about your very important and continuing. In fact, you also gave a theme that women's rights and COVID-19 gaps and challenges. So over to Professor Sangamitra Acharya. Ma'am.
Okay, thank you so much, Zia. What I'm going to try and do is take this conversation forward as we've done this in this session. And for that, I would probably begin by thanking once again the university. Okay, I'm also trying to share my screen. I hope I'll be able to do that. Okay, I think I've managed to do that. The Vice Chancellor, Professor Ainul Hassan Sahab, I was really hopeful that I'll be able to be there present physically for this occasion, but then I'm sure there are other things which which just don't allow us to do certain things that we want to do. So I am connecting on this. I'm probably going to just take this conversation forward through some of the slides that I would share with you, by way of probably pointing out how the whole debate has arisen in the global community and what is it that we've done at our end, particularly in terms of certain disparities, certain vulnerabilities of women that have been pointed out by in the morning session, and also in the previous two by the previous two speakers very, very aptly. So I'm just trying to perhaps build upon where my colleagues, my co-panelists have left this conversation. I'm going to move ahead from there. I'm not too sure whether my screen is visible or not visible.
Not yet. Yeah, it is coming.
It is coming. So it takes a while before it becomes visible. But how do I do the rest of the job?
You have to move on to PowerPoint page, ma'am. No.
My PowerPoint is
PPT.
open.
Go to now PPT. If you go to PPT.
I should go on the PPT.
Yes.
Okay, I'm there. Is it visible?
Yes, it's
okay.
Visible.
Fine. Sorry, I was wondering how do I do this now. It's really okay. So I'm going to go full screen. That's what I'm supposed to do, right?
Yeah. If you hide that at the bottom of this slide.
Yeah.
Yes.
Yeah. Is it okay now?
It's all right. Yes.
Okay. So like I said, I'm just going to raise those very questions which we've been said since morning and reiterate some of the aspects by way of bringing in some examples from what the global community has done and engaged with versus what we see in terms of our own nation and our own communities. Now, I am trying to go a step beyond the fundamental rights. I think human rights is what I would want to peg in vis-a-vis the reproductive rights. And why we really need to see this connect is simply because way back when the Charter of United Nations was being put in place, it was very importantly seen that for any kind of interaction across nations, it was important to see how do human rights function or how do human rights are adhered to in order to ensure very fundamental freedoms for populations. And therefore, I think that's the connect which brings us to think along the lines of the reproductive rights, wherein this respect, this identity, this protection that we see or we consider important for human beings becomes very, very relevant. And the morning session, Professor Mala Ramanathan had already brought in this context of ICPD, wherein the reproductive rights have been seen in the light of human rights. So I think moving ahead from then, a quick glance at what have been the major deliberations vis-a-vis the concern wherein reproductive health has been considered. Way back when we think about the congregations which had started thinking about population, and precisely for the reason of the growing population in the less developed countries, and how that is what was supposed to be addressed in cooperation with the developed countries. The first conference way back in 1927 takes note of this distinction, or I wouldn't want to use the word disparity, but this difference between the then developing countries vis-a-vis the developed countries. From there, perhaps a lot of concerns were raised and efforts put in together in order to address this growing population of developing countries. So much so that by the time we come in mid 1950s, the UN Population Conference, which was held in Rome, very categorically lays down the prepositions that there is a need to reflect upon how the continuous, consistently upward trends of the population growth in less developed countries who have also remained poor countries needs to be addressed. Subsequent global conversations in the form of these conferences also suggested the same, till we actually arrive at the Bucharest Conference of 1974, wherein health becomes a fairly important consideration, which is seen vis-a-vis what was happening to the conversation which was being built upon for curbing the growing population. This is the point where in health and the note for health, and that's where in some ways maternal and child health gets embedded, because of which we see a couple of years down the line, just about 4 years down the line, the Alma Ata Declaration happened, putting the primary health care in a very, very relevant or core kind of a position when one had to deal with population. So the point, therefore, I'm trying to make at this level is that while reproductive health was a concern, was a realm in this conversation of population and connecting population with development, particularly because of consumption disbalance between the less developed and the developed countries, it was very, very importantly noted that health is something which we cannot do without, right from the maternal and child health to the general health of the population. But the thrust, of course, remained on the maternal health, because that's where perhaps pegging the population growth could have been made better as compared to the other realms of health. So we also have the conversation which is taken forward during the subsequent 84 International Conference on Population in Mexico, wherein the less developed countries kind of question what was suggested at Bucharest as development is the best contraceptive, whereby much of the contraceptive support in the form of reproductive health care was supplied to the less developed countries, which was kind of questioned by the proponents of inequitous distribution of resources, that it's the development per se which will actually curb the population, not the direct curtailing, direct supply of support for curtailing the population, which was fairly much kind of elaborated by way of bringing reproductive health in a big way in the core of this whole debate, which was generated for population. And something which is very importantly seen now at this time point is that this growth of population, or the obsession with the growth of population, is kind of being connected with the processes of development, and therefore the realms of health becoming very important, realms of women becoming very important, gender disparity becoming very important, whereby we also see the very next year, 1995, we have the International Conference on Gender and Development. So the content of this whole conversation about the realms in population, realms in development, realms in health, have a trajectory which blends with each other, and which also brings to the fore that all of these, or the triangulation of these realms, cannot be overseen without looking at the social disparities. And that's where perhaps we also then start taking note of the larger global conversation on the realms of racism, starting way back in 2001 at Durban, and there have been subsequent discussions on social development. And there are plenty of other localized discussions which have also been held. So much so that now in 2015, we kind of have aggregated all of this and reflecting on these aspects vis-a-vis sustainable development. Now, if we have to peg everything on sustainability of development, and I'm using this very consciously, because something which we, first of all, what exactly could be development in itself has to prove its worth by way of ensuring that if it is beneficial for somebody or some groups, it shouldn't be detrimental to some other groups. But the reality is that we know that these are the lacunae of most development processes. Dams and irrigation projects are the live examples for this. But not getting into that debate, I want to bring ourselves to this very argument that I'm trying to raise vis-a-vis the global discussion which has happened in the realms of this trajectory between health and development, and therefore population to begin with, really puts together the ideas wherein we need to think about what exactly therefore is reproductive health in its own self. Why does it become so important that we need to bring it in the realm of choices and rights, etc., etc. Much has already been said since morning, but just to reiterate what exactly we could be thinking across when it comes to reproductive health in a very generic sense. As an individual human, I do have the right to be able to decide what would be the sexual realms of my life. What are the freedoms that I can exploit vis-a-vis my choices in terms of being informed about the services which could be available? What are the nuances through which I could probably access these services? Are they affordable? Are they acceptable methods of whatever family building processes that may be put across? Am I informed about the processes of regulating my fertility, or am I given that kind of information which is necessary for me if I'm going to engage with processes such as these? So right from the decision making to perhaps conception to childbearing to post child delivery nuances, I think there are very specific realms in which the reproductive health in terms of understanding gets completely located. And therefore, the realm of care provisioning and care use becomes very, very important. The ones who've been providing the care pertaining to reproductive health, and those who require the help pertaining to reproductive health becomes very, very important. But most of the time, the peg is on women, and that's again the kind of social, realms that we are in, the patriarchal systems of societal norms and customs that we are in. Instead of considering this as the basic rights of the couple, the men and the women who would probably be engaging in exercising anything that could be in the nuance of reproductive rights and reproductive choices, a lot is pegged against individuals. Not that individuals are not important. Individuals actually comprise the couples, but the uneven power relation, if I can use that phrase, between a couple also perhaps pegs that more on women as compared to men. Nevertheless, the importance, the realm is that the couple or the individual has to have that basic right to be able to decide about this family building process. But we all know that it's not so much the couple who takes the decision, it's the larger familial setups, larger community setup in which the couple or the individuals could be located become important in kind of in enabling that decision to be made. information is very often minimal when it comes to embarking upon these decision-making processes. A lot of there are evidences and ample of them during pandemic, which have kind of distorted this decision-making process. There were evidences of discrimination on the axis of age, gender, sex, caste, class, religion, and all of this. I'm sure we've ample examples of this. Coercion and violence, of course, however much we might want to say that conjugal rights are enshrined in a marital relationship, but conjugal rights, dispensation of conjugal rights very often become the male partner's prerogative as compared to the women. So in these kind of backdrops, when we actually start this conversation about what are reproductive rights, sometimes I feel that it's kind of a paradoxical situation in which we are trying to deal with, despite the fact that ICPD tells us very, very categorically that the elements which are embedded within reproductive rights include the right to decide freely and responsibly the number of children a couple may be interested in, spacing of the children, and in addition to that, information as pertaining to these spacing aspects of family building process. But given the information that we've just had in the previous discourses, the lack of systems, which kind of the halting of the system, the halting of the services, the dispensation of the services over about 3 to 4 months' time, in a way, unavailability of the contraceptive methods, contraceptive pills, etc., in itself has impacted on not only the information but the actual process that could have happened. So it really becomes very, very difficult to be able to not kind of condition ourselves in terms of thinking about how much of these elements are being executed in any which form vis-a-vis social, cultural, and legal formats in which we are embedded. The very, very idea of early marriages, for example, breach that enshrined right that we perhaps might be interested in discussing about. So, so when we actually consider these international bodies and their versions of how we understand reproductive health, we have to connect these in the local systems and local scenarios, and then perhaps get a feel of how best can we ensure contraceptive choices and safe infertility services. How do we improve maternal and newborn health? What are the context of reducing STIs and HIV particularly? What are the unsafe abortion realms? How do we reduce them? Dr. Rane has already stated categorically that that's one aspect we really need to do. And how do we promote healthy sexuality? And that's here perhaps I would wish to bring in the realms of alternative sexual choices. Most of the time in any such discourse, we ignore the transgenders, for example. We just talk about men and women per se in terms of all these services and all these programs that could be available, need to be made use of, etc., etc. But the issues that have come up regarding the LGBTQI vis-a-vis even access to vaccination services, I think we need to revisit much of this whole simplified version of how do we actually understand the sexual and reproductive health in context of adolescent. Of course, our predecessors have brought on board, but I just wanted to connect these enshrined assumptions or enshrined probabilities to how we see the reality actually happening. Going back to the much talked about National Family Health Survey, I just want to mark for ourselves, like, while we do see, because literacy levels are pegged fairly high in terms of creating awareness, giving us that enabling environment to be able to access services, to be able to question, to be able to ask for what my right would be. Despite the fact, if you look at the levels of women who are literate, has improved fairly much from about 55% to 68% to now 73%, 72%. By the time we've reached to 2018-19. In fact, the survey spilled over into 2020 also. We still have, women almost to the tune of a quarter of women who are getting married below the age 18. And this is, we're talking about as late as just about 2 years ago. We also have women, something to the tune of 7%, who are still becoming pregnant, or they're already kind of, already have a child by the time they are in this age group, 15 to 19, just about a year older than the legal age at marriage. No, I mean, I do understand, I do agree that there has been a reduction from 16% to about 7%, but the fact that this is still happening is where I would kind of wish to draw the attention. Similarly, while we do see very, very, very encouraging improvements in both infant and child mortality levels, we also see the access or use, perhaps, and therefore I would relate it to access to any kind of contraception is still stacked at about 67%. And therefore, I think the realms of total unmet need, wherein close to 10% remains as the decision vis-a-vis giving birth to the children, and roughly to the tune of 4% when it comes to spacing the children. So the point I'm trying to make over here is perhaps that while we have made certain fairly impressive gains when it comes to the time period that we are referring to, early, let's say, 2000s to late 2000s, we do still have a lot more to perhaps connect with and do that. And this is where perhaps the pointer is that despite this kind of a scenario where we are seeing an upward trend vis-a-vis women's literacy, etc., changes in conception, in marriage age, etc., we still have just about 42% of women who have access to money wherein they can take any decision regarding their own health. And I'm seeing this in the Connect because while 75% of women are in a position to take care of take a decision regarding their own health, meaning to say whether they would want to see a doctor or they would want to stay back and take some home remedies, any kind of decision which is viable for their health need. They only less than half of them have any access to money. So you can imagine what kind of decision making must be happening over here, and who are the care providers where they could be going to for this kind of for any service for that matter. So while it becomes important to recognize that they are participating in decision making, fairly interestingly, 70+%, the access to resources to be able to execute that decision making perhaps also becomes important, and that's where perhaps access to money, access to be able to use that money becomes extremely important for them to kind of to be able to do anything, So this probably takes us to the next level, wherein the vulnerability of these positions bring an entirely different dimension of the right-based, realms of gender and women that we often want to discuss and talk about. As early or as late as 2015-16, we are in that kind of situation where more than 50% of women and about 42% of women feel that it's all right if the spousal violence happens because of the reasons as varied as goes out without telling him, doesn't take care of the house, argues with the spouse, refuses to have sexual intercourse, doesn't cook properly, any kind of suspicion, disrespect for the in-laws. I mean, these are valid reasons to get beaten up and to beat up, because more women, in fact, as compared to men, are all right with it. But the saving grace is that over the 2015, 16 and 2018, 19 or 2018, 20, we do see declining trends which have been reported in terms of spousal violence, physical violence during pregnancy, and of course youth don't seem to be changing anything over the 2 time point. But let's remember that this is also the time point wherein a lot of restrictions happened because of COVID having arrived, and in fact the last phase of the data collection for NFHS actually happened during the COVID times. So in that kind of a backdrop of empirical evidence that we have vis-a-vis how, where do we position women, it probably becomes important for us to get a sense of what actually has COVID done to the reproductive rights and choices. We've already discussed in the morning hours that something which very interestingly we've noticed already, the number of births happening in homes, at homes, has risen almost 3-fold as compared to earlier time points, which is precisely because of the services which were closed down and couldn't be, even if the services open, transportations were not available. So the whole social landscape, whole realms within which individuals' lives have been located, from the economic outcomes to the intimate relationships, they've all kind of completely changed. Childbearing preferences, the contraceptive use, access to any kind of health services, telemedicine becomes an alternative, and of course the exposure to the whether we call it intimate partner violence or spousal violence, perhaps, we do see kind of a very contrasting kind of scenario which is existing. Stay home policy was largely to save the individuals from exposure to the virus, right? But this exposure, non-exposure, quote unquote, to the virus exposed women to a different kind of burden. And that's what perhaps gets recognized as the shadow pandemic, wherein within this pandemic, the violence which was being executed to women because they had to stay home, most probably with people with whom they were not safe enough, with whom they were not conducive in relationship, and were expected to stay home, locked in those environs. So this is what was happening to the women in general. The other dimension, if we want to bring in, or we need to bring in, is the realm of social inequalities, which have brought the burden very, very differentially across social groups. But sadly enough, we don't really have any data to talk about other than the crowdsourced data or the micro studies that have been conducted. And I'll try and share some of the outcomes of a couple of micro studies with which I have been associated with. So when we are looking at COVID-related mortality as well as morbidity, the mortalities have been higher among the people who have been vulnerable in terms of color, particularly if you're bringing in the Western countries in the realm, the underprivileged communities vis-a-vis caste and tribal groups. We really have no idea what has been happening to the groups who are remotely located, geographically remotely located in certain pockets, whom we identify as tribal populations. Particularly those who are in these scenarios, in rural scenarios, remote rural areas. there's no data breakup that we have, neither in terms of gender, nor in terms of age, nor in terms of social identities. State level, some state some state agencies have managed to put some of these identifiers together. So when we are looking at this gender inequality vis-a-vis what has happened in Western countries, and I'm giving this example of USA because this is something I was reading very recently. And this I'm sure has happened across the board. It's more women who have lost their jobs as compared to men, because again of the vulnerabilities in which the women seem to be located. The probable breadwinner seemingly had to be given way by most women, not really being able to return to their jobs in that sense. So if we take note of some of the anecdotal reports and blogs and press media accounts, we do get in these realms that it has impacted the sexual and reproductive health very, very poorly. Just about to quote from one of the studies which has come up very recently by Population Council, which very, very categorically brings the fact to us that because of the COVID, the face-to-face interactions with the grassroots level workers was almost nil. And therefore, a lot of services which could be provided by way of mouth. I could communicate to the ASHA and the A&M vis-a-vis my friends in the village, etc., for a particular need, which would get communicated because of the communication across women in the local setups. The services could be provided. Now, here is the absence of face-to-face services, and therefore the restrictions which are put in place because of social distancing. And I have problems with this phrase also. Maybe some other time we'll discuss this. Nevertheless, but these restrictions imposed that kind of barriers wherein access was completely halted, and therefore the results are fairly much evident to us in terms of unsafe abortions, which were inevitable, because if I needed to abort and I had no regular formal service available to me, probably I would have visited somebody whom I thought will be able to provide me the kind of service I was in need of. So in-person, provisioning of services was kind of, we can really pointedly say that there was a decline, something to the tune of 10%, very, very neatly, wherein, this is again from the global scenario. It's really amazing, to talk about, to see that a similar kind of scenario is visible even when we are making some kind of reflections using the crowdsourced and micro-level studies. And I'm saying this because going back to the same reference that I've just kind of shared with you, if we see that because of COVID, when we are kind of talking about reproductive choices and reproductive services, even before engaging in the family building processes, the preferences that one may have about beginning the childbearing process, starting the family building process in that sense. If we have about 40% women who kind of change their plans, considering that probably COVID will not be the right time to have a baby, there were also similar reflections that we see in India through one of the micro-level studies, which was done in about 208 migrants who got stranded. We followed them up for a period of about 6 to 7 months and tried to continue with the conversation through which some of them have come back to Delhi and a couple of other cities where they have kind of relocated themselves. So the point I'm making is that this whole idea of developed versus developing countries, despite the fact that we just about spend less than 2% of the GDP on the health sector, which we need to enhance, while if you're looking at USA, something to the tune of 11 to 12% of the GDP goes into health. Despite that, the similarities of situations when it comes to fertility preferences, right? One in three women in US kind of delayed or did not want to visit any healthcare facility because of, again, I might catch the infection. The scenario over here is more than half the women did not do that and could not do that, rather, again, by similar kind of strictures. Again, the similar situation which we might want to again consider women in terms of looking at decisions to whether to have a child now or delay it for some other time point. We again see a similar kind of trend, but the quantum for sure is far more for us as compared to women in the Western countries. So the point perhaps I'm trying to make here is that while we do not have a system which needed to be in place, a lot of discussions in academia and in the policy making regimes have kind of suggested that there is a need to increase the budgetary allocation for health care. And this is perhaps the time which tells us very, very importantly that what we are doing today, 1.17% of the GDP, is absolutely not enough, even if what the 2021 the budgetary presentation by the finance minister said that we'll now increase it to about 2.5 to 3%. Perhaps given the scenarios that we've just rolled out or are still reeling under, even that may not be may not be adequate, because while we are not able to ensure the family planning services to roughly, if I go by the NFHS 4 estimates, roughly 3 million women remain, in want of any kind of contraception and abortion. This certainly has skyrocketed during the pandemic, and we see that about 70% of health and social workers who are women, and I'm sure we've already heard this earlier, and they are, right there in the grassroots doing their jobs, but without any kind of protective measures, even now, if we might want to kind of take a look at. We have no information, we have very little data on considerations such as this. So, so the point therefore I'm making is that we probably need to look beyond a couple of things by way of which we try to understand the reproductive health, reproductive care, reproductive choices, and bring on board the role of state over and above what perhaps it becomes relevant for us to argue for. Now, despite the fact that even by way of the larger global discourse on ICPD vis-a-vis WHO, our own Ministry of Health and Family Welfare kind of assures that pregnant women must be provided with all essential services. But very, very categorically, a couple of states which I'm listing here, Uttar Pradesh, Bihar, and Kerala, did halt the programs, including the ANC and the door-to-door services which need to be provided. And therefore, the point is that as we see that provisioning of the services was halted, what needs to be seen in also is the reason why these services were halted, right? And that's where perhaps a larger frame of adherence to lockdown becomes relevant in terms of availability of transportation, for example, availability of the care provider, for example, or caretaker within the household, for example, so that it enables the mother who needs to go out for care can perhaps do that. So all of this perhaps becomes very relevant in taking cognizance of how could the state services, state in generic terms, the health services could actually take care of when we are in this realm of public-private partnership. 70% of the private hospitals having shut down on the pretext of, not having adequate manpower or staying away from the infection, safeguarding the personnel, etc., etc. I think becomes a bit of a paradox when we are trying to take cognizance of a situation such as this. So much so that I was very appalled to get to read one of the local newspapers from Kanpur, which stated that a doctor who was in the government hospital, the district hospital, I'm forgetting the name that has been ascribed to it, the doctor had been serving through the COVID period, including the second wave. A couple of weeks back, he was found having killed all his family members, which included his doctor wife, a son and a daughter who were also placed fairly well, and his own body was found, I think a couple of days later somewhere, with a note which said that I have seen enough during COVID and I cannot face the Omicron anymore. So this is something which perhaps in the form of note, and it's apparently about 3-page note which the doctors left behind, saying how unprepared he is for the coming wave of the surge. So the point, I think, is that how stressed the individual care provider could have been to be able to take a step such as this. So just an instance wherein what is being under what is the stress under which these individuals have reeled in terms of providing services, health particularly, and all tiers of health, right from perhaps the ones who were taking decisions versus those who were executing, and Dr. Vaswani has already pointed out what was happening to the sanitation workers within, particularly in the hospice, because they perhaps were in the direct contact with the body fluids, beddings, etc., etc. So some of those aspects, I think, becomes very, very relevant. And now, just to bring in, I hope. Sorry, I'm already overshot the time. So just to bring in the realm which perhaps was already spoken in the morning, when we are actually talking about how do we safeguard the women's right in terms of reproductive choices, in terms of her own health, I think the very document that we fall back upon, or very principles that we fall back upon, is the Article 12 of the Committee of CETO. And that's where the very clear commitments have been made, and we as one of the partners have probably brought that on board, but execution again becomes something important for us to take note of. And that's where perhaps I would want to peg in when the generic entity of women in the country do not seem to be having the fair kind of chance to be able to access the resources, what perhaps could be happening to women who are vulnerable on the basis of their social identity, on the basis of being differently abled, or on the basis of tribal identity, and so on. And I just pick up one of the vulnerable identities, which is the Dalits. Now, again, going back to relying on the NFHS 5 data, it's very appalling to note that if all these services that we've been talking about, all these choices that we've been talking about, are supposed to be for everybody, each one of us are supposed to be, all of us are supposedly equitably, we should be able to access these services, we see a gap between the very lifespan. When we look at women from Dalit communities, they live almost 15 years, 14 and a half years less than women who are from privileged groups. So with this kind of disparity already existing, it's not very shocking that we see more children who are reporting problems in accessing any kind of healthcare among the Dalits versus those who are from the privileged groups. 70 to roughly 60%, 10 percentage points, more than 10 percentage point gaps. Similarly, the experience of distance to a given facility where a care provisioning can happen, or availability of a care provider, almost to the tune of 18 percentage points vis-a-vis the privileged communities in case of distance, and roughly about 4 to 5 percentage points in terms of availability. And there are micro-level studies which do tell us that when we are looking at the access, geographically, most vulnerable communities are located in the outskirts. So there's a possibility of the distance becoming one of the important factors why access to services cannot happen. Similarly, there are a couple of micro studies, including one of mine, which was done in the western parts of the country. It come out very clearly that when I am an underprivileged user of a service wherein I have to interact with the healthcare provider, the time spent with me by the provider is lesser than the time spent by somebody who is from a privileged community. So I think that's where perhaps the nuance of to re-embark or reiterate the constitutional rights becomes very, very important. And I really wish to bring about this judgment of Justice K.S. Puthuswamy versus Union of India, which kind of very, very vociferously says that constitutional rights of women has to be seen in the light of their reproductive choices, because that's part of the personal liberty which is already enshrined under Article 21. And despite all of these international regimes that we've probably talked about earlier, also reiterating the fact that all of this, I'm sure, like we have these constitutional and legal safeguards for various population groups. All other countries also have. But despite all these regimes that we have had across over the period of time, we do have the gaps which need to be seen. And therefore, I would want to invoke this thinker which India has produced, and many of us recognize him as the messiah of the downtrodden. But I want us to think of him beyond that. To me, he is one of the thinkers which the nation has produced, who embarked upon the concerns for women's health way back in early 30s. The Bombay Legislative Council discussion, which was held on 10th of November 1938, this is where I think his realms of care for women's health becomes very, very evident, wherein he almost suggests that reproductive rights of women are fairly important for their own development, for the development of the children, and therefore limiting the family size to ensure her health and the health of the children is important and needs to be taken care of, unlike what the states promoted vis-a-vis for controlling the population size. And that's the difference I would want us to recognize at this moment. So therefore, the point I'm making is that in recognition of the relevance of women's health in the sector of development for development processes, he goes on to kind of take note of something what was happening in the mica mines. I'm sure many of us would be familiar with, which becomes the foundation of the Labour Welfare Fund Bill, by which we also get the benefit of what we now recognize as maternity leave. The maternity benefits to working women were proposed and kind of put in place way back in 1942, all because of the efforts which was put across by this visionary thinker that the country has produced. So I think, to my mind, therefore, I would want to close here by saying that while we have the international fora considering the realms of the trajectory wherein we locate reproductive health, we have the state as an agency which is having certain directives. We have community and the familial systems within which women is anyway embedded, and therefore the maneuvering of these choices happen. What becomes really important is to locate what could be the proactive realms within which the rights could be forwarded, put across. And in the given realms of COVID, I think systems wherein assimilation can happen vis-a-vis the online whatever mode for whatever service we might be using. The inclusive modes become all the more important in this times of health pandemic, be it the care providers in the health sector, or it could be the providers who could give us jobs, or it could be the regular industrial setup which is providing us with certain services, wherein perhaps the needs of women, right from the general health to menstrual hygiene to reproductive services, can get located. So the intersections between these coordinates, between these trajectories become very, very important if we really want to make sure of the gendered choices that can be made for the reproductive health of both men and women. Not to forget the points of infertility which were made earlier this morning. I'll stop here, and sincere apologies. I think I've really overshot that time. I didn't realize that I'll do this. Thank you so much. You might want to take over, or just advise me, how do we take this forward now? We might have questions. I'm sure I would be happy to field them.
Thank you so much, ma'am. I would request now.
To stop sharing?
Yeah, that can be done. Yeah.
I can stop sharing,
So,
right? Yeah.
yeah, it has stopped. It has stopped.
Okay.
That was really very insightful and quite informative presentation. And Professor Shahida was just sharing that how informative every slide is, that we need too long hour to discuss on various issues. That makes some presentation very important. And I would meanwhile request Professor Shahida to come, and if she was to enter into this and then share few her ideas and comment upon the paper if she has.
The page है. Topic वाला. Good evening. I don't know whether Veena must have left, and also Madam Swati Rani. But I don't know, I fall short of, expressing my happiness, contentment, at the end of the day today. What a fulfilling, sessions we have from morning till afternoon until evening. Thank you, each one of you who have enriched us. In true sense, I'm telling, it's not just a formality. Each slide of yours, it was so, so, so informative. And a very novel way of, I found here with you, ma'am, your presentation, Madam Acharya, that you have brought in Ambedkar's thought here. The Dalit aspect to it. What I'm much interested was in intersectionality and approach, which is very much essential. I'm really fortunate to have a diverse speakers, resource persons here. And all the thank goes to Professor Vibhuti Patel, who has provided me lot of inputs how to go about and provided these two beautiful women who just spoke. Of course, I know you, and I don't know whether they are still linked. I don't think they are. But from my, bottom of my heart, I would like to really thank all of you for taking the, discourse to its various aspects. It was so inclusive in all the sense, in all the sense. I wish that it was offline conference and we could have some, uh, many more people who could have contributed to the discourse, raised some real questions which could have further enriched the dialogue on an important aspect like this. And I was very particular to have this gender lens, and I'm thankful to you, madam, that you talked about transgender. ऑफ कोर्स एलजीबीटी में हमें सबसे ज़्यादा तो ट्रांसजेंडर का ख्याल करना है एंड हमने किया and we also have to talk about the marginalized and you raised that and I'm so glad that you spoke about that. Now from here I'm trying to take up uh, the onus is on me now how best I can produce this work in a book form.
Yes.
Little work on your presentation today, you can just make it a great paper, ma'am. And also, I request others to do that. Previously, I think some 3 months before, I have had a conference on related issues. Acha, Swati, are you there? You're peeping and disappearing. Yeah, I thought you have left. So, thank you. A big thank you to you. You have a great, this really, young generation doing lot of work on this and your narratives will be very very because I used to chat with you talk with you the nurses contribution towards and the narratives definitely will really be enriching giving a real picture of when we publish or we do and bring it to the for people to provide a window to peep into what is happening to the medical services there and the intersectionality. How the people from the margins suffer far more than the people who are more privileged like us, who could afford many more things, but not this. The situation was so bad. We have seen from very close quarters. Maybe there is another day we may discuss about the migrants issue during COVID-19. So inhuman. The whole system. I was just talking to Zia that we're talking about women who couldn't afford maybe the medical services, inaccessibility to the medical, what you call like pills and whatever the contraceptive, it was not accessible. But how about those vulnerable children who were closeted with the male relatives at home? The female, the mothers and the wives have suffered untold misery. Because once the men are in home, there was no really respite from their very, they become very, aggressive, no job,
Yes.
no money.
Yes.
All the
Yes.
time, women have to accept. And there was high rise, in the domestic violence. Not only that, there are quite many cases of fence eating the grass, cases of, small kids. And then the second part was, as so many of you have raised about the early marriages. So either way, the women are at the receiving medically, non-medically, but sexual and reproductive health stands out in all this process, and I think it's going to continue. God forbid, I don't know, Omicron or no Omicron, the COVID has written again to knock at our doors. So don't know how vulnerable our future is for the women. Very, very vulnerable because the intersectionality is very important to and have an perspective because ये जो मार्जिन्स में है, गरीब हैं, illiterate हैं, dropouts girl हैं, early marriages, they are pushed into also trafficking. Also trafficking. Many cases you see the girls are being pushed because they want some money back. उनको खाने के लिए ही नहीं है तो गुर्बत तो कुछ भी करा सकती है आपसे. So again the women, at the focus of sufferance, you see. So don't know what plan of action can we suggest to those who are at home. हमने मेडिकल को अब देखिएगा, वार्ड में बच्चियों का रेप हो रहा था, वार्ड बॉयज वर रेपिंग. कैन वी फॉरगेट दैट? How vulnerable the whole, it has given a larger perspective में औरत को रखा है COVID-19.
जी बिल्कुल बिल्कुल.
तो ये ना, it is exposing only the red zone. It has just converted, red completely. Maybe there was some hidden thing which we were not aware of. Look at the migrants, what happened to the walk, how they walked the distance, miles together. What happened to the pregnant women? The baby is dropping on the road,
Yes,
pregnant mother
absolutely.
dying. Can we forget those scenes? We can't. We need to, I don't know where all we have to shake. Can we raise one question here? Why the government machinery was inactive? Why the army was not activated to prepare food in large amount and then distribute to the migrants?
Absolutely.
नंगे
But the
पैर
sad,
चल रहे थे, उनकी
sad
गाड़ियों
thing
का
is that
इस्तेमाल क्यों नहीं हुआ?
absolutely, absolutely.
The
गाड़ियां ही चला
role
दी
of the
जाती.
state, the role of the state we cannot forget, ma'am. And I feel that here also in the policy, we have to add the role of policy, state. State cannot be a mute spectator. The onus has to go to the state. एक तो पॉवर्टी, दूसरा कास्ट सिस्टम, हमारे पास कितने इंटरसेक्शनैलिटीज नहीं है. And imagine those sex workers coming on the road begging, कि our earning has gone because of the COVID.
They removed
Transgender
their
people.
electricity, ma'am. In Maharashtra, they
Exactly.
removed the electricity of the sex
What
workers
I,
and they were begging.
yeah,
Yes.
yeah.
And they couldn't beg also because nobody was ready to give them anything. So they had come.
Exactly. Because I read their narratives. They said, what is happening to us? You're talking about you and me. How about those margins? Within margin. So we need to
Even
really, there's a whole set of, a debate need to be done on various issues. But this to start with really, and I'm going to maybe, ma'am, about the minorities, Muslim
yes,
minorities, how
absolutely.
the whole debate of CAA and all, how the ghettoization of Muslims, the denial of their
Absolutely.
rights, and what is happening. Muslim women have to fight within their own system, you
Lot
know,
of
and then outside also as women, as a Muslim
Absolutely.
women within their patriarchal structure, how to be,
Absolutely.
build. You can't afford to build our men. I want to
Absolutely.
protect that, and then later I have to fight from outside. And what is happening? Always the women are at the helm of the, like somehow the exclusionary practices. What is happening to the citizenship rights? We need to discuss anyway. But I'm pray that I get some sort of funds. I want to adopt 2 large Muslim dominated slum areas where we have had earlier. I had done a very small survey and I found very pathetic situation. It's
Yes.
not that Asha worker ki things have come now, but on daily basis we find that there's lack of service, like from them also, because a lot of complaints we received. But all said and done, there are always two sides to a coin. COVID-19 apart, but otherwise, I think we require a lot of improvement in government services and government hospitals, because I got a survey done in government hospitals. How the women are treated when they are in labor pain, how
Yes.
they were moved from one place to one place, they were thrown away without any vehicle, like from the centers, medical health center. She,
Yes.
on the way, during the transit, she dies for want of attention, medical attention that she cannot afford. So intersectional approach is so very important to have, because ours is a diverse country,
Yes.
and we need
Yes.
to take into account, apart from gender, there are many others, which are axes which we need to, because gender is not the only axis we have to, there are many other we have to think of. And I don't know how to thank all of you who have made my day our day, and you provided such information. I tell you, I request Swati, you are here, please fill up the gaps, complete the paper and send also.
Yeah.
Let the PPT be here, but I request you really to just complete that paper and send me. I'll also request Veena madam to do that, because this I can't afford to miss. This I can't afford to just let go. It has to be bound in a book form and then given. Thank you so much for everybody. Thank you so much, Zia. I want to really thank the Vice Chancellor, the Pro Vice Chancellor, the Registrar, and my great friend Mamta. I wish that you were here to listen to her beautiful explanation, that she had a topic which is very close to each one of her heart, that is right to abortion for rape victims, rape survivors. It was a wonderful discussion which moved our Vice Chancellor very much. And he said that there should be some more get togethers like that, and we need to discuss threadbare all these aspects of, writing in Constitution. Article 21 gives you all, but see, it doesn't percolate down to reality. That's where the contradiction come, and we need to discourse like this. One day is not sufficient, we need to meet again and again, and then have other aspect discuss over here. Maybe next time minority women will take and then discuss.
Absolutely. Absolutely.
And really, thank you so much, IMC, Rizwan, and team, who have been always, always a great backbone to me, to come anytime, like it is my, drawing room. Just to give a call to them, and they are ready, whole team. And I thank them. I appreciate all their cooperation. And my only staff here, Amina Tabassum, who is behind, who did all the running errands, doing everything, whatever the shortcoming, I accept. And really claps to all of them. My greatest brother here, Zia, whom I can just give a call and then he rushes and come. Thank you so much, Zia, for being there always. Thank you, everybody. Thank you.
Thank you.
Thank you, ma'am, for giving us the opportunity.
Thank you so
Just-
much. We really look forward.
Yeah.
Thank you so much. In fact, without somebody like Shahida ma'am, this program would not have been possible. And she is always there for so many important issues to debate. So with this, we end the last session of this today's webinar on reproductive choices. Thank you everyone. तमाम लोगों का बहुत शुक्रिया कि आप लोग सुबह से शाम तक जुड़े रहे, ऑनलाइन अपने कुछ सवाल भी पूछते रहे. मुझे उम्मीद है कि आप लोगों को ये प्रोग्राम पसंद आया होगा, और आने वाले वक्त में इसी तरह के कुछ अहम मुद्दों पे हम बहस मुबाहसे करेंगे. ये भी बात हमने देखा और पढ़ा कि कई स्टूडेंट्स ने ज़ुबान के लिए कहा कि अंग्रेज़ी में बोली जा रही हमें नहीं समझ में आ रहा है. ये भी एक प्रॉब्लम है. तो जो ये एक मसला है ज़ुबान के साथ, लेकिन उर्दू यूनिवर्सिटी में हम उर्दू में अमूमन बात करते हैं. चूँकि ये डिजिटल आर्काइव का भी हिस्सा होगा, हमारे मीडिया सेंटर के यूट्यूब चैनल का भी हिस्सा है, ये प्रोग्राम हमेशा मौजूद रहेगा, तो लोग बाद में भी आराम से इसे सुन सकते हैं. हमारे यूनिवर्सिटी के और बाहर के तमाम यूनिवर्सिटी के कोलीग्स का भी बहुत शुक्रिया कि आप प्रोग्राम से जुड़े और अपने इस वक्त को हमारे साथ गुजारा. बहुत अहम था ये हमारे लिए. मीडिया सेंटर के तमाम लोगों का बेहद मेरे तरफ से भी शुक्रिया, क्योंकि वो उमूमन इन प्रोग्राम्स के लिए उन्हें बैठा रहना पड़ता है और हम लोग बोलते रहते हैं. बैठना और बोलने में बहुत फ़र्क होता है, लेकिन उनकी इस हिम्मत, उनकी उस जज्बे के लिए हम उनका शुक्रगुजार हैं. आखिर में हमारे साथियों से ये गुजारिश करता हूँ कि प्रोग्राम के आखिर में नेशनल एंथम को सुनाया जाए. लेट अस विल स्टैंड फॉर द नेशनल एंथम.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विन्ध्य हिमाचल यमुना गङ्गा उच्चल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशिष मागे गाहे तव जय गाथा जनगण मङ्गलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Thank you so much.
So we can leave now, right?
Yeah.